Hey everyone. If you're prepping for your boards or just trying to get up to speed on your clinical rotations, you are in the right place. We're about to do a super high yield, no fluff review of the key medications for obesity. We're going to cover exactly what you need to know to crush your exam questions and, more importantly, to make really smart choices for your patients. All right, let's jump right in. So here's our game plan. We'll start with the basics. Who even qualifies for these medications? Then we'll march right through the major drug classes, basically in order of how well they work. We'll hit the big ones, the incretins, then the oral combo pills, that one-of-a-kind fat blocker, and the short-term options. And then we'll wrap it all up with a rapid-fire review to lock it in for test day.
Okay, first things first, and this is critical. Medications are always in addition to lifestyle changes. We're talking diet, exercise, and behavioral support. The pills are a tool, not a magic bullet, and they don't work well in a vacuum.
So this really gets to the heart of the clinical question, right? You're in clinic, you've been counseling your patient on lifestyle, they're giving it a real effort, but they're just not hitting those weight loss goals. So when do you actually reach for that prescription pad?
Well, here are the two classic indications you have to burn into your memory. First, anyone with a BMI of 30 or higher. That's the definition of obesity, plain and simple. Or, second, a patient with a BMI of 27 or higher if they also have at least one big weight-related health problem. You know, things like high blood pressure, type 2 diabetes, high cholesterol, or obstructive sleep apnea.
So you've started the medication. Now what? How do you know if it's actually working? This is your key number. You are looking for at least a 5% loss of their total body weight after 3 months on a full dose. If they don't hit that mark, the drug just isn't the right one for them. It's time to stop it or switch to something else. All right, let's get into the drugs themselves. And we have to start with the most important and effective class out there, the incretin therapies. These are your first-line agents, and honestly, they have completely changed how we approach obesity medicine. They're true game changers. So how do these things work so well? Well, it's this awesome 1-2 punch. First, they work centrally, up in the brain, to ramp up the feeling of fullness or satiety. And second, they work peripherally, in the gut, to slow down how fast the stomach empties. Both of those things make patients feel full, and that's the secret sauce to their incredible power. And when I say power, I mean it. Just look at these average weight loss numbers from the trials. Liraglutide gets you around 8%. Semaglutide is way up there at about 15%. And then there's Tirzepatide, which hits both GLP-1 and GIP receptors. We're talking over 20% weight loss. I mean, that's just staggering. A few years ago, you only saw numbers like that with bariatric surgery. So let's say you're deciding between the two heavy hitters, Tirzepatide and Semaglutide. How do you choose? Well, if the number one goal for your patient is just getting the maximum amount of weight off, the data would point you towards Tirzepatide. But, and this is a big but, if your patient has known cardiovascular disease, Semaglutide is your go-to. It's been proven to reduce cardiovascular events in major trials. Of course, no free lunch. The main side effects for this entire class are gastrointestinal. We're talking nausea, sometimes vomiting, and diarrhea. But here's the key. The way you manage this and keep people on the drug is by starting low and going slow. You have to titrate the dose up very gradually, usually every 4 weeks, to let the body adapt. And here it is. This is your 5-star guaranteed to be on the exam question. What is the absolute contraindication for GLP-1 agonists? It's a personal or family history of medullary thyroid cancer, or NMEN2 syndrome. You absolutely have to screen for this. It's a non-negotiable safety check. Okay, what if your patient can't take an injectable? Maybe they have a needle phobia or issues with access. Our next stop is a couple of very effective oral combination pills that work up in the brain. We've got two main players here. First, Phentermine-Topiramate. This one is very effective, giving you about 10% weight loss. But it has a huge red flag. Topiramate is highly teratogenic. It can cause cleft palates. You must get a pregnancy test before you even think about starting it. The other option is Naltrexone-Bupropion. This gives you about 5% weight loss and can be great for patients who really struggle with food cravings. Its big red flag, bupropion lowers the seizure threshold, so it is an absolute no-go in anyone with a history of seizures.
Next up, we've got a drug that's in a class all by itself. Orlistat is totally different. It doesn't work on the brain, it works right in the gut. But as you'll see, that unique mechanism comes with some pretty significant tolerability issues.
The mechanism here is super simple to understand. Orlistat is a lipase inhibitor. It just blocks the enzymes that break down fat in your food. So about 30% of the fat someone eats never gets absorbed. It's literally a fat blocker.
And this is where the mechanism directly leads to the side effects. If that fat isn't absorbed, it has to go somewhere. And this leads to that infamous side effect profile. Oily stools or steatorrhea, fecal urgency, sometimes even accidents. And these symptoms can be so unpleasant that a lot of patients just can't stick with it long term.
And here is a super important clinical pearl. If you're blocking fat absorption, you're also blocking the absorption of fat-soluble vitamins. That's A, D, E, and K. So patients have to take a multivitamin, but the key is they can't take it with the Orlistat. The best advice is to have them take it at bedtime, at least 2 hours after their last dose.
All right, let's talk about our last class of meds, the sympathomimetics. The absolute key thing to remember about these drugs, when they're used by themselves, is that they are for short-term use only.
Phentermine is the classic example here. By itself, it is only FDA approved for 12 weeks of use or less. Now, you might see it used off-label for longer periods, but for your exams, you need to know that 12-week limit.
And why is it so limited? Well, it's a stimulant. It works like an amphetamine. So it's a hard stop for patients with serious cardiovascular issues like uncontrolled high blood pressure or coronary artery disease. It's also off limits for anyone with hyperthyroidism or a history of drug abuse because of its potential for misuse. Okay, let's bring it all home with a quick, high-yield summary. Just think of these next few points as the flashcards you absolutely have to know before you walk into your exam.
First up, the GLP-1s. Remember, these are your first-line agents. They have the highest efficacy for weight loss, period. And their absolute contraindication is that personal or family history of medullary thyroid cancer, or MEN2.
Next, Phentermine-Topiramate. This is your most powerful oral option. Its #1 contraindication is pregnancy because it's a known teratogen. That means you have to get a pregnancy test before you prescribe it, every time. And finally, Naltrexone-Bupropion. This is a solid choice for patients who really struggle with food cravings. So what's its major must-not-miss contraindication? That's right, seizure disorders, because bupropion lowers the seizure threshold. If you can remember these key red flags, you're going to be in great shape, both for your exams and for taking care of patients in the future.